So picture this. You are standing in an operating room. The patient's oxygen saturation suddenly drops to, say, 70%.
Which is terrifying, by the way.
Right. And then the end-tidal CO2 waveform just completely flatlines on the monitor. You have roughly 3 minutes to secure an airway.
3 minutes before irreversible ischemic brain damage sets in. It's nothing.
It's absolutely nothing. In that hyper-compressed window of time, your cognitive bandwidth as a clinician is just completely saturated.
Oh, absolutely. You are managing multiple failing physiologic systems, and at the same time, you're probably directing a room full of panicked personnel.
Yeah. And if you need to reference a protocol or check a drug dosage or verify some difficult airway algorithm, the source you pull from has to be absolutely unequivocally reliable.
It has to be, because if you act on an outdated summary or, a poorly vetted app, that 3-minute window closes. And the outcome is catastrophic.
Welcome to the deep dive. Today we are exploring something that you might think of as simply putting someone to sleep. But in reality, anesthesia is this fast-moving, protocol-driven tightrope walk.
The margin for error is practically non-existent. We are talking about a field where you are purposefully inducing a state of controlled physiologic failure.
Right, like apnea, loss of airway reflexes.
Like profound vasodilation, myocardial depression. You are doing all of this and then constantly titrating it against surgical stimulus to keep the patient walking on a razor's edge.
And in that environment, the information architecture supporting your decision-making is just as critical as the oxygen flowing through the circuit.
I would argue it's even more critical, honestly.
So that is exactly what we are dismantling today. We have a massive stack of source material for this deep dive.
We really do. We're looking at methodological reviews from the American Society of Anesthesiologists, historical analyses of cognitive aids.
Which actually trace back to aviation crew resource management, which is super fascinating.
Yeah, and deep dive pharmacodynamic texts, plus comparative studies on localized institutional protocols.
But the mission here is not to just list a bibliography of books you should buy. We are investigating a fundamental question.
Right. When an anesthesiologist, a nurse anesthetist, or a resident is in the thick of a high-stakes clinical scenario and needs trustworthy guidance, what actually makes a source reliable?
Like, how do professionals evaluate the information ecosystem when acting on bad data is literally a lethal event? It's like flying a commercial jet. You don't just Google how to land in a crosswind while on final approach.
No, you definitely don't. And evaluating that reliability requires a highly sophisticated level of critical appraisal.
Because, medical professionals operate in a reality where they are constantly bombarded by information, right?
The volume of medical literature published daily is staggering. It's impossible for one human to keep up with.
So evaluating reliability isn't just about finding something that is peer-reviewed.
Exactly. It is about understanding the specific utility, the methodological rigor, and the clinical applicability of different tiers of information.
You have to know when to rely on the deep mechanistic explanations of a foundational text versus when to defer to the population-level data of a society guideline.
Or when to strictly adhere to the rigid branching logic of a crisis cognitive aid.
Which brings us to our first major hurdle. Because the natural instinct, even for highly educated trainees entering the field, is to seek the path of least resistance.
It is human nature.
Right. In the digital age, that usually means pulling out a smartphone, opening the App Store, and downloading whatever medical reference tool has the most 5-star reviews.
Or the slickest user interface. I see it all the time.
It's a phenomenon of cognitive offloading. You have residents who are sleep-deprived, totally overwhelmed by the sheer volume of pharmacology and physiology they need to memorize.
So they naturally gravitate toward these high-yield summaries, bullet point study guides, crowdsourced flashcards, that sort of thing.
Which introduces what we can call the popularity fallacy in medical education.
I love that term, because popularity, search engine optimization, algorithmic visibility, these are terrible metrics for clinical reliability.
Just because an app has 1 million downloads doesn't mean it's safe.
Right. It might have 1 million downloads because it's free, or because it successfully gamifies the studying process for medical boards.
But a slick interface just provides an illusion of competence.
It tells you the what without establishing the why. And in anesthesia, if you don't understand the underlying physiologic mechanism, you cannot adapt when a patient deviates from the textbook presentation.
Let's drill down into that illusion of competence. Let's compare the architecture of a major foundational text, something like Miller's Anesthesia or BRASH, with a quick reference mobile app.
Okay, great example.
If I look up a drug like dexmedetomidine on a high-yield app, it's going to give me a bulleted list, right?
Very brief. It'll say alpha-2 agonist provides sedation without respiratory depression.
Side effects include bradycardia and hypotension. Loading dose is X, infusion rate is Y. It's highly efficient.
It is efficient, but it is dangerously reductive.
Why dangerously?
Because a foundational textbook does not just list bradycardia as a side effect and leave it at that. It dedicates pages to explaining the precise mechanism.
The actual biology of what's happening.
Exactly. It explains the presynaptic alpha-2 agonism in the locus coeruleus that decreases norepinephrine release.
Wow. Okay.
And more importantly, it differentiates the central sympatholitic effects from the transient peripheral alpha-2b receptor activation.
Wait, what does that peripheral activation actually do?
Well, it might actually cause an initial hypertension and reflex bradycardia upon a rapid bolus.
Oh, so the app strips away that entire biphasic cardiovascular response.
Completely. The app just says bradycardia and hypotension.
So if a clinician relies solely on the quick reference tool, they push a loading dose of dexmedetomidine.
And they observe a sudden spike in blood pressure followed by a drop in heart rate.
They would probably immediately panic, right?
They'd think they've administered the wrong drug or triggered a catastrophic event.
And then what? They intervene with something else.
Yeah, they might intervene inappropriately with a fast-acting antihypertensive, completely destabilizing a patient who is actually just having a normal, expected physiological response.
That is wild.
Mm-hmm.
So the foundational text builds the deep physiological scaffolding.
It builds your clinical gestalt. You read those 3,000-page texts outside the operating room.
You synthesize the pharmacodynamics and pathophysiology at home, basically.
Right, so that your pattern recognition in the operating room is rooted in first principles.
Okay, but let me push back on this reliance on massive text for a second.
Sure, go ahead.
The fundamental science of human anatomy and baseline receptor physiology doesn't undergo paradigm shifts every Tuesday, you know? Like, the GABA-A receptor operates the same way today as it did 10 years ago. So why is an older edition of a foundational textbook treated as a dangerous liability? Like, if the mechanics are static, isn't the obsession with having the absolute newest edition just, I don't know, academic pedantry?
I see where you're coming from. Anatomy and baseline receptor physiology might be static, but our understanding of pharmacogenomics is incredibly dynamic.
Okay, fair.
Subtle pathophysiological interactions, the statistical outcomes of massive population data sets, these change constantly.
Can you give me an example?
Sure. A textbook from 10 years ago might accurately describe the mechanism of action of a specific neuromuscular blocker.
Right, the basic science is solid.
But it will completely lack the data on newly developed reversal agents. Or maybe there are recently discovered black box warnings regarding its use in patients with specific, newly classified myopathies.
Ah, I see. So the drug works the same, but our context for using it safely has shifted entirely.
Exactly. Medicine has shifted from a model of static authoritative knowledge to dynamic, evidence-based practice. Relying on an outdated text means you are operating on a deprecated data set.
Which really exposes the inherent limitation of textbooks in general.
They are slow.
Super slow. By the time a comprehensive, multi-author textbook goes through the writing, editing, peer review, and publishing cycle,
the references cited within it are often 3 to 5 years old by the time it hits the shelf.
So it is an indispensable tool for learning the fundamental architecture, but it cannot serve as the arbiter of current best practices.
Precisely. The textbook gives you the mechanistic why, but to define the current standard of care, the what we must do right now, professionals have to pivot.
Pivot to a completely different tier of the information ecosystem.
Right. They must look to the major professional society guidelines.
And this is where we get into the heavy artillery of medical literature.
Oh, absolutely. The heavy hitters.
We are talking about documents produced by organizations like the American Society of Anesthesiologists or the American Society of Regional Anesthesia and Pain Medicine.
Or SOP, the Society for Obstetric Anesthesia and Perinatology.
Right, and these guidelines represent the synthesis of thousands of data points. But, I mean, how does a clinician evaluate the reliability of the guideline itself?
That's the million-dollar question.
Like, what is the actual methodological machinery happening behind the scenes to produce these recommendations?
It all comes down to the transparency and rigor of the evidence grading process.
Evidence grading. Okay.
Yeah. When a professional society convenes a task force to write a guideline, they don't just, sit in a room and debate based on their clinical experience.
It's not just a bunch of experts saying, well, back in my day, I did it this way.
No, not at all. They employ rigorous methodologies, frequently utilizing frameworks like the GRADE system.
GRADE. Let's break that acronym down because it is crucial for understanding how medical consensus is actually forged.
So GRADE stands for the grading of recommendations, assessment, development, and evaluations.
Okay, and it's not just a binary do this or don't do this kind of thing, right?
Far from it. It's an assessment of the quality of the evidence, coupled with the strength of the recommendation.
That distinction feels paramount.
It is. So, the task force conducts exhaustive systematic reviews and meta-analyses. They aggregate all available literature on a specific clinical question.
And then they grade the quality of that evidence.
Right. So, a massive, multi-center, double-blind, randomized controlled trial, an RCT that will start with a high evidence quality rating.
Because it's the gold standard of study design.
Exactly. Whereas an observational study or a retrospective chart review starts with a lower rating.
Why is that?
Because of the inherent risks of confounding variables and selection bias. You just can't control the variables as tightly.
But they don't just accept RCTs at face value either, do they?
No, they don't. They will downgrade the evidence if there is severe methodological limitation in the study design.
Like a really small sample size.
Yeah, or if there is wide inconsistency between different trials. Or if there's evidence of publication bias, where only studies with positive results were published.
Which is a huge problem in medical literature.
It really is. Now, conversely, they can actually upgrade the quality of observational evidence.
Really? Under what circumstances?
If the magnitude of the treatment effect is massive and undeniable, or if a clear dose-response gradient is observed.
Okay, so once they have established the quality of the evidence, high, moderate, low, or very low, what's the next step?
Then they formulate the strength of the recommendation.
So a strong recommendation means what?
It means the task force is highly confident that the desirable effects of an intervention heavily outweigh the undesirable effects.
And a weak or conditional recommendation.
That implies a finer balance. It means the best action may differ depending on the specific patient context. It requires shared decision-making.
To ground this in the reality of the operating room, let's look at a highly specific, notoriously high-stakes scenario.
Let's do it.
Neuraxial anesthesia in the presence of anticoagulants.
Oh, this is a classic high-stress situation.
We are talking about placing an epidural or a spinal block. The anesthesiologist is driving a needle through the ligamentum flavum into the epidural space.
Or through the dura into the subarachnoid space. And keep in mind, this is a space that is heavily vascularized by the epidural venous plexus.
Right. Lots of blood vessels. And if the patient is taking a direct oral anticoagulant, a DOAC like apixaban or rivaroxaban,
Blood thinners, essentially.
and that venous plexus is punctured during the needle placement, the patient lacks the ability to form a clot.
Which means they bleed into a closed, rigid space. The spine doesn't expand.
So the resulting spinal hematoma compresses the spinal cord, leading to permanent ischemia and irreversible paraplegia.
It is a catastrophic, life-altering outcome.
So the anesthesiologist absolutely must know the precise time interval required between the patient's last dose of that blood thinner and the needle placement.
And this is exactly where the informal cheat sheet or even the foundational pharmacology textbook completely fails the clinician.
Because the textbook will just tell you that rivaroxaban is a factor D inhibitor, right?
Right. And the quick pharmacokinetic app might tell you its half-life is 5 to 9 hours in healthy adults.
But neither of those data points answers the actual clinical question. When is it safe to place the block?
Because the half-life is not a static number.
Right. It changes based on the patient.
Exactly. The clearance of these drugs is highly dependent on renal function.
The kidneys.
Yes. If a patient has a glomerular filtration rate of 25 milliliters per minute, their kidneys are barely clearing the drug.
So that 5 to 9 hour half-life extends dramatically.
Massively. Furthermore, the anesthesiologist has to consider the trauma of catheter removal.
Oh, right. It's not just about when you place the needle.
No, it's about when you pull the epidural catheter out 2 days later, and when you can safely restart the anticoagulant postoperatively without causing a delayed hematoma.
So this is where the clinician turns to the ASRA guidelines, the American Society of Regional Anesthesia.
And these guidelines are incredibly granular.
They don't just say, wait a few days.
Not at all. They matrix the specific drug against the patient's creatinine clearance, the dosage level, whether it's prophylactic or therapeutic, and the specific procedural risk.
So they might stipulate a 72-hour hold for a high-risk procedure and extend that to 120 hours if the patient has renal impairment.
Exactly. And the reliability of that ASRA guideline stems from the fact that the committee has aggregated every available pharmacokinetic study, case report of spinal hematoma, and manufacturer data set.
But here is the critical marker of a trustworthy guideline, right? Transparency about limitations.
That is the hallmark of true reliability. A reliable society guideline will explicitly state when the evidence is weak.
So in the case of newer anticoagulants, the ASRA authors openly acknowledge when recommendations are based on pharmacokinetic modeling and expert consensus, rather than massive randomized trials.
Simply because running a randomized trial to see how many spinal hematomas occur would be deeply, deeply unethical.
Yeah, let's see how many people get paralyzed. Yeah, no board is approving that study.
Exactly. So that transparency allows the clinician to gauge their own risk tolerance.
If the guideline says grade 1A recommendation, you follow it rigidly.
But if it says grade 2C recommendation, you have room to exercise clinical judgment based on the specific patient's risk of thrombosis versus their risk of bleeding.
But this massive methodological rigor creates a secondary problem.
The lag time.
The lag time. Compiling Cochrane-level reviews and moving them through organizational bureaucracy takes years.
It does. It takes a frustrating amount of time.
So are these monumental guidelines inherently outdated the moment they hit the presses?
It is the inherent friction between the speed of scientific discovery and the necessity of rigorous vetting.
So how are societies handling that?
Well, to mitigate this, many major societies are abandoning the static 5-year publication cycle in favor of living guidelines.
Living guidelines, meaning they are constantly updated.
Yes, they are digital-first documents. When a practice-changing, multi-center RCT is published in, say, the New England Journal of Medicine, the task force convenes virtually.
They don't wait for the next 5-year summit.
Right. They run the new data through their established methodology, and they update the specific node of the guideline in real time.
Okay, so the living guideline solves the currency issue. It's up to date.
It does.
But it doesn't solve the cognitive bandwidth issue we talked about at the top of the dive.
Not even a little bit.
Because society guidelines are incredibly dense. We are talking about nuanced, heavily footnoted PDFs spanning 50, sometimes 100 pages.
They are the absolute gold standard for preoperative planning, protocol development, and establishing the baseline standard of care.
But they are completely useless when the patient is actively crashing on the table.
Which necessitates a total paradigm shift in how information is formatted and consumed.
When a planned procedure devolves into a crisis, we leave the realm of deep analytical thought.
And we enter the realm of cognitive aids, algorithmic branching logic, and crisis resource management.
We are talking about designing information for the panicked brain.
Yes. Let's dive into the neurobiology of stress, because it dictates the entire architecture of these emergency manuals.
Let's do it. When a routine extubation suddenly turns into severe laryngospasm, where the vocal cords just clamp shut, or an induction triggers massive anaphylaxis, what happens to the clinician?
The clinician's sympathetic nervous system goes into absolute overdrive.
The fight or flight response.
Exactly. The amygdala detects the threat and floods the system with catecholamines, epinephrine, and norepinephrine, along with cortisol.
And this neuroendocrine cascade is fantastic if you need to, run away from a bear in the woods.
Right. But it is highly detrimental to executive function in an operating room.
Why is that?
The surge of cortisol essentially dampens the prefrontal cortex, which is the part of your brain responsible for complex problem solving, logical sequencing, and working memory.
And working memory is fragile on a good day. Most people can hold maybe 5 to 7 pieces of information in their active working memory.
But under severe physiological stress, that capacity can drop to 1 or 2 items.
That's terrifying.
The clinician experiences auditory exclusion, temporal distortion, and a highly dangerous phenomenon known as task fixation.
Task fixation. This is where a practitioner becomes hyper-focused on a single failing intervention, right?
Exactly. For example, they might spend 10 uninterrupted minutes attempting a direct laryngoscopy, just trying over and over to place a breathing tube.
Completely ignoring the fact that the patient's oxygen saturation has plummeted to lethal levels.
Yes. They fail to transition to an alternative airway strategy because they are locked in.
They lose the forest for the trees because their prefrontal cortex has effectively been hijacked.
Oh, this is where the aviation industry had to step in and teach medicine a very hard lesson about human fallibility.
Aviation. Right.
Yes, because for decades, the medical culture was built on this myth of the infallible physician.
The idea that a highly trained doctor should be able to rely on their massive intellect and perfect memory to navigate any crisis without help.
Right, but aviation realized long before medicine that human memory is fundamentally unreliable under pressure.
Especially after several catastrophic airline crashes in the 1970s.
Crashes that were attributed to human error and poor team communication, not mechanical failure.
So the aviation industry developed crew resource management and the mandatory use of cockpit checklists.
They realized that when an engine fails at 30,000 feet, the pilot shouldn't be trying to creatively brainstorm a solution.
They shouldn't be debating aerodynamics.
No. They should execute a highly refined, predetermined sequence of actions designed to stabilize the aircraft.
And medicine finally adopted this, leading to the creation of cognitive aids like the ASA difficult airway algorithm and the Stanford emergency manuals.
And the design language of these tools is fascinating if you really look at them.
They are not written in paragraphs.
No, they utilize stark typography, aggressive color coding, and rigid branching logic.
Because the visual design is intentionally engineered to bypass the overloaded prefrontal cortex.
Exactly. Let's examine the evolution of the ASA difficult airway algorithm.
Okay.
The true brilliance of this algorithm isn't just that it provides a list of tools, it fundamentally restructures the clinician's priorities.
Because historically, the priority was always intubate the trachea.
Right, but the algorithm shifted the paradigm to maintain oxygenation.
It provides a rigid cognitive scaffold. It explicitly defines the transition points.
Yes, if you attempt direct laryngoscopy and fail, the algorithm forces you out of that task fixation.
It demands that you move to a different strategy, perhaps inserting a supraglottic airway or using a flexible intubating scope.
And crucially, it limits the number of attempts you are allowed to make before you are forced to declare a cannot intubate, cannot ventilate scenario.
And once you hit that point, you move immediately to emergency front-of-neck access, like a cricothyrotomy.
Exactly. It removes the ambiguity. And it incorporates the physiological realities of the situation, emphasizing preoxygenation.
Right, denitrogenating the functional residual capacity of the lungs.
To maximize the safe apnea time. The algorithm is essentially a physical manifestation of best practice heuristics designed to be read and executed in seconds by a team operating under massive cognitive load.
Another prime example of this is the management of malignant hyperthermia, or MH.
Oh, absolutely. MH is a rare, life-threatening pharmacogenetic disorder.
If a susceptible patient is exposed to volatile anesthetic gases like sevoflurane or the muscle relaxant succinylcholine, what happens?
Their ryanodine receptors essentially lock in the open position. Calcium floods the skeletal muscle cells, causing massive, unchecked muscle contraction.
So the patient's metabolism goes into hyperdrive.
Yes, producing massive amounts of carbon dioxide and heat. Their core temperature can rise a degree every few minutes.
The clinical presentation is sheer chaos, right? Sudden tachycardia, skyrocketing end-tidal CO2, muscle rigidity, profound metabolic acidosis.
It is a nightmare scenario. And if you are relying on your memory of a textbook chapter you read during residency 5 years ago, the patient will likely die.
You don't try to remember the milligrams per kilogram dose of the antidote.
No. Someone immediately grabs the physical MH crisis manual, which is usually brightly colored and attached to a dedicated MH cart.
And the design of that manual is a masterclass in crisis resource management.
It utilizes linear checklists that assign specific roles to specific people.
It doesn't just say administer dantrolene, the antidote.
Right. It explicitly details the workflow required. Because historically, reconstituting traditional dantrolene required injecting 60 milliliters of sterile water into dozens of 20-milligram vials and shaking them vigorously until the powder dissolved.
Which requires a massive physical effort. You literally have to have strong arms to do it fast enough.
Yes. So the manual tells the team leader to assign a dedicated person or multiple people solely to the task of reconstituting and pushing the drug,
while assigning someone else to actively cool the patient and someone else to manage the severe hyperkalemia, the hypotassium that results from the muscle breakdown.
It completely removes the cognitive burden of delegation and dosage calculation.
But I want to challenge this reliance on algorithmic medicine for a second.
Okay, let's hear it.
If we train an entire generation of clinicians to blindly execute flowcharts the moment a monitor alarms, don't we run the risk of creating medical technicians rather than expert diagnosticians?
That's a common critique.
What happens when a patient's presentation is atypical? Like, if the algorithm says do X, but the clinicians gestalt their deep, intuitive understanding of the patient's specific pathophysiology screams that X will kill the patient.
How do they reconcile that?
Right. Do algorithms breed dangerous complacency?
That is the central tension in algorithmic medicine. It is a highly debated topic in the literature. However, the purpose of a cognitive aid is to raise the floor of clinical performance, not to lower the ceiling.
Raise the floor. I like that.
Algorithms are designed to manage the vast majority of standard presentations and to prevent obvious errors of omission.
Like forgetting to call for a surgical airway kit while attempting multiple intubations.
Right. They are a cognitive safety net. They prevent the catastrophic, unforced errors caused by panic.
But they aren't a straitjacket.
Exactly. A true expert utilizes the algorithm as a baseline structural framework. If a specific step in the algorithm is contraindicated by the patient's unique physiology, the expert clinician relies on their foundational knowledge, the knowledge built from those massive textbooks, to safely deviate from the pathway.
So the algorithm provides the default action, which actually frees up the clinician's remaining cognitive bandwidth to analyze the nuances of the atypical presentation.
Yes, they are complementary layers of safety.
That perfectly transitions us to the next layer of complexity.
Let's get into it.
Once you've navigated the crisis algorithm, or if you are simply managing the ongoing minute-to-minute physiological state of a stable patient, you're constantly making micro-adjustments.
You are administering powerful intravenous drugs, vasoactive drips, opioids.
And managing that pharmacology requires a highly specific tier of references, specialized drug dosing, and perioperative medication guides.
Because the pharmacology of anesthesia is vastly different from internal medicine or general practice.
How-
Well, a primary care physician might prescribe an oral antihypertensive and evaluate its efficacy over a period of weeks.
Right, you take a pill and come back in a month.
An anesthesiologist administers an intravenous bolus of propofol and observes profound loss of consciousness and cardiovascular depression within 30 seconds.
The onsets and offsets are highly compressed,
And the pharmacokinetics are incredibly complex.
which is why a generic medical app, like Hippocrates or a basic nursing drug handbook, is often insufficient and sometimes dangerous in the operating room.
Anesthesia-specific guides don't just give you a static dose, they have to account for multi-compartment pharmacokinetic models.
Break that down for me. Multi-compartment models.
When you administer a bolus of an anesthetic agent, it doesn't just uniformly distribute throughout the body all at once.
Okay.
It rapidly fills the central compartment first, the blood and highly perfused organs like the brain and the heart. That's what causes the rapid onset of action.
Right, they go to sleep fast.
But then the drug redistributes into the peripheral compartments, the muscles, and eventually the fat.
And if you are running a continuous infusion of a drug, rather than just a single push, you have to worry about the context-sensitive halftime.
Precisely. And this is a massive concept in anesthesia.
Explain context-sensitive halftime, because it's totally different from a regular half-life.
Right. The context-sensitive halftime is the time required for the blood plasma concentration of a drug to decrease by 50% after an infusion is stopped.
Okay.
And crucially, it is dependent on the duration of the infusion. That's the context.
So, for example,
A drug like fentanyl might have a short duration of action after a single bolus because it rapidly redistributes out of the blood and into the fat.
the patient wakes up quickly.
Right. But if you run a continuous fentanyl infusion for 8 hours during a long surgery, those peripheral fat compartments become completely saturated.
Like a sponge that can't hold any more water.
Exactly. So when you turn the pump off at the end of the surgery, the drug leaches back out of the fat into the blood.
So the context-sensitive halftime skyrockets.
And the patient may not wake up or breathe adequately for hours.
Compare that to a drug like remifentanil.
Remifentanil is brilliant. It is metabolized by plasma esterases directly in the blood.
It doesn't rely on redistribution or hepatic clearance by the liver.
No, so its context-sensitive halftime is essentially flat, about 3 to 5 minutes, regardless of whether you run the infusion for 10 minutes or 10 hours.
You turn it off, and they wake up 5 minutes later every time.
Yes. And a reliable anesthesia pharmacology guide details all these specific kinetic profiles.
It provides the data necessary for utilizing target-controlled infusions, or TCI.
where sophisticated infusion pumps use algorithms like the Marsh or Schneider models for propofol to target a specific concentration of the drug in the patient's brain.
Constantly adjusting the infusion rate based on the patient's age, weight, and the pharmacokinetic model.
Exactly. And the complexity of these guides multiplies exponentially when we step away from the standardized 70-kilogram healthy adult male model.
Right, because how do these specialized guides handle the extreme physiological deviations seen in pediatric or obstetric populations?
Because treating a neonate like a tiny adult is a recipe for disaster.
It is a fundamental error. Pediatric physiology is radically different. Let's look at inhalation inductions putting a kid to sleep with gas.
Okay. In an adult, breathing sevoflurane gas to go to sleep takes time.
But a neonate has a vastly different alveolar ventilation to functional residual capacity ratio, the VAFRC ratio.
Yes. Their VAFRC ratio is roughly 5-to-1 compared to an adult's 1.5-to-1.
Meaning they're breathing relatively larger volumes of air in and out compared to the baseline volume of air just sitting in their lungs.
Exactly. This leads to an incredibly rapid wash-in of anesthetic gases. They go to sleep in seconds.
But it also means they have massive vulnerability.
Because their baseline oxygen reservoir, the FRC, is so small, and their metabolic oxygen consumption rate is so high, they desaturate and become hypoxic with terrifying speed if they stop breathing.
Furthermore, their cardiovascular system doesn't respond to drugs the same way.
Not at all. An adult can increase their cardiac output by increasing stroke volume, the amount of blood pumped with each beat.
But a neonate's myocardium is relatively non-compliant. It's stiff.
So their cardiac output is almost entirely rate-dependent.
Meaning if you administer a drug that causes bradycardia, a slow heart rate in a neonate, you aren't just slowing their heart rate.
You are directly and severely plummeting their cardiac output and their blood pressure.
Specialized pediatric anesthesia guides are built on data that accounts for these developmental differences.
They outline how minimum alveolar concentration, or MAC requirements, actually peak at around 6 months of age, requiring relatively higher doses of volatile anesthetics than adults before gradually decreasing with age.
The same extreme deviation applies to obstetric anesthesia, doesn't it?
Oh, definitely. When an anesthesiologist is managing a pregnant patient, particularly during an emergency cesarean section or a complicated labor, they are managing two entirely distinct physiologic systems.
Connected by the placental barrier.
Right. And the physiologic changes of pregnancy are profound. By the third trimester, maternal blood volume has increased by up to 50%.
Which radically alters the volume of distribution for intravenous drugs. You need different dosing.
And the engorgement of the epidural venous plexus actually decreases the volume of the epidural and subarachnoid spaces.
Meaning you need significantly less local anesthetic to achieve the same level of neuraxial blockade compared to a non-pregnant patient.
Exactly. If you gave them a standard adult dose, it would spread too high and compromise their breathing.
And then there's the mechanical issue of aortocaval compression.
A huge factor. When a full-term pregnant patient lies flat on her back, the gravid uterus physically crushes the inferior vena cava against the spine,
Drastically reducing venous return to the heart and causing profound hypotension.
which compromises uteroplacental perfusion, starving the fetus of oxygen.
So a reliable obstetric guideline, such as those published by SOAP, dictates the necessity of left lateral uterine displacement.
Tilting the patient to the left to get the uterus off the blood vessels.
Furthermore, these specialized guides must detail the placental transfer kinetics of every single drug administered.
Because if you push a massive dose of a highly lipid-soluble drug, it crosses the placenta.
But it gets even more complicated if the fetus is distressed. Let's look at local anesthetics. If a fetus is hypoxic and becomes acidotic, the pH of the fetal blood drops.
This creates a dangerous pharmacokinetic phenomenon known as ion trapping.
Ion trapping. Unpack that for us.
Local anesthetics are weak bases. They cross the placenta in their non-ionized lipid-soluble form.
Okay, so they pass freely into the baby.
Right. But once they enter the acidic environment of the distressed fetal circulation, they become ionized. They pick up a proton.
And in this charged, ionized state, they can no longer cross back over the placenta to the mother.
They become trapped in the fetus, accumulating to potentially toxic levels.
The General Medical Handbook is not going to adequately highlight the risk of ion trapping of bupivacaine in a distressed fetus.
No, it won't. You need the highly specialized, rigidly vetted data from obstetric-specific literature to guide those decisions.
But this brings us to a massive friction point in this whole deep dive.
Oh, what's that?
We have established that society guidelines and specialized texts represent the gold standard of scientific data.
The ivory tower of evidence-based medicine, yes.
But what happens when that ivory tower collides with the gritty, logistical reality of a community hospital?
That is where the rubber meets the road.
Right. What if the pristine, peer-reviewed guideline says you absolutely must use a specific advanced video laryngoscope for a complex airway, but the hospital you are standing in simply doesn't own one?
This is the ultimate crucible of medical reliability, and it introduces the final and often most practically important layer of the information ecosystem, the local institutional protocol.
Because you can have the most methodologically sound, heavily researched international guideline in the world.
But if it is practically unexecutable in your specific clinical environment, it is useless. Reliability must encompass clinical applicability.
Let's explore this friction. Let's look at a massive transfusion protocol, or MPP.
Okay, great scenario.
A patient is bleeding out perhaps from a ruptured abdominal aortic aneurysm or severe trauma.
The national guidelines on massive hemorrhage resuscitation have heavily shifted toward utilizing point-of-care viscoelastic testing, like TEG or ROTEM.
TEG being thromboelastography.
Right. Instead of just running standard lab tests that take 45 minutes to result, a TEG machine provides a real-time graphical representation of the entire coagulation cascade.
It tells you exactly how fast the clot is forming, the ultimate strength of the clot, and whether the clot is breaking down too quickly.
It allows the anesthesiologist to administer highly targeted, goal-directed therapy.
Giving cryoprecipitate if the fibrinogen is low, or platelets if the clot strength is weak, rather than just blindly dumping blood products into the patient.
And the national guidelines strongly recommend this goal-directed approach because it improves survival and reduces the massive waste of blood products.
Okay, but what happens if you are the lone anesthesiologist on call at a rural 50-bed critical access hospital at 2 a.m. a.m.?
You don't have a $50,000 TEG machine in your operating room.
Right. Furthermore, your blood bank is minimally staffed, and they don't have an unlimited supply of separated blood components.
This is precisely why the local hospital committee must take the national framework and adapt it to their physical reality.
The local MTP protocol might mandate a fixed ratio resuscitation strategy instead.
It might dictate that the blood bank automatically sends coolers containing packed red blood cells, fresh frozen plasma, and platelets in a strict 1.1.1 ratio.
It's not the highly targeted, individualized therapy recommended by the international guideline.
No, but it is the safest, most reliable method of preventing the lethal triad of trauma, hypothermia, acidosis, and coagulopathy using the actual resources available in that building.
The local protocol must also account for sheer logistics.
Logistics dictate everything in medicine.
If a national guideline states that a specific reversal agent, like iMedix, should be administered within 3 minutes of a cannot intubate, cannot ventilate scenario to rapidly reverse a rocuronium blockade.
That is scientifically sound. It works brilliantly.
But iMedix is notoriously expensive. A hospital pharmacy formulary might restrict its storage to the central pharmacy rather than keeping it in every single operating room Pyxis machine.
And if the central pharmacy is 3 floors away and requires a pneumatic tube system or a runner to deliver the drug, that 3-minute window is impossible to meet.
The local airway protocol has to reflect that logistical barrier.
It might force the clinician to utilize a different muscle relaxant strategy entirely, like relying on acetylcholine, simply because the ideal reversal agent isn't geographically accessible in an emergency.
But this geographic variance introduces a massive medical legal complication. I want to look at this from the perspective of standard of care.
Okay, this gets tricky.
Imagine a traveler, a locum tenens physician, or a traveling nurse anesthetist who jumps between different hospitals. At a massive academic center in Boston, the standard of care is absolutely to use TEG-guided resuscitation and immediate iMedix reversal.
They internalize that as the gold standard.
Then they take a contract at a small regional hospital in the Midwest. If a patient suffers an adverse outcome and a lawsuit is filed, how does the law reconcile the national guideline against the local protocol?
Right.
Can a clinician be sued for malpractice for following a local protocol that is technically inferior to the national guideline.
It is a complex area of medical jurisprudence, often evaluated under frameworks similar to the Bolam test or local standards of practice. However, generally speaking, the law recognizes resource limitations.
So they don't expect you to do the impossible.
Right. The standard of care is typically defined as what a reasonably competent practitioner would do under similar circumstances with similar resources.
Okay, that makes sense.
You cannot be successfully faulted for failing to utilize a piece of technology that does not exist in your facility, provided your facility's local protocol was built upon a reasonable adaptation of the available evidence.
In fact, ignoring your local, heavily vetted institutional protocol in a vain attempt to blindly execute a national guideline that your hospital is not equipped to support is a significantly higher liability.
Absolutely. The local protocol is the operationalized standard of care for that specific building.
But that requires extreme mental agility. A clinician must constantly unlearn the ingrained muscle memory of their previous institution and rapidly assimilate the local reality of their current environment.
The recipe might be written by the Michelin star chefs at the National Society, but the local clinical director is the one looking in the pantry to see what ingredients are actually on the shelf today.
I love that analogy.
Yeah.
Which brings us to the ultimate synthesis of this entire discussion. When we look at the complete architecture of reliable anesthesia guidance, we realize it is not a monolithic entity.
It is not a single textbook, a single app, or a single PDF.
It is a layered, interlocking system of safety nets.
Yeah.
You start with the massive foundational texts to build the deep physiological and mechanistic understanding.
You need to know how the GABA receptor works and how the alveolar gas equation functions.
Then you layer on the professional society guidelines, the ASRA guidelines on anticoagulation, the ASA guidelines on fasting.
These provide the rigorously graded, evidence-based standard of care for preoperative planning and protocol development.
Then you incorporate the highly specialized literature to handle extreme deviations in physiology.
Like the SYAP guidelines for obstetric patients or specific pediatric references, understanding that specialized populations break the rules of general pharmacology.
And when all the planning fails and the sympathetic nervous system kicks in, you abandon the dense texts entirely.
You rely on the rigidly designed cognitive aids, the airway algorithms, the MH manuals, the emergency checklists. You rely on visual design and branching logic to bypass task fixation and save the patient's life.
And tying all of these layers together to the physical floor of the operating room is the local institutional protocol, which filters the ideal science through the reality of the hospital's pharmacy, blood bank, and equipment supply.
A true clinical expert doesn't just know the information. They know exactly which tier of the information ecosystem to reach for at any given millisecond.
It is an incredible symphony of information management. But as we close out this deep dive, I want to look at the horizon.
The future of medical data.
Exactly. We have spent the last hour discussing books, PDFs, society task forces, and laminated checklists hanging on carts. But the landscape of medical data is currently undergoing a seismic shift.
We are rapidly entering the era of artificial intelligence, machine learning, and highly integrated electronic health records.
The integration of clinical decision support systems, or CDSS, directly into the perioperative monitor.
It's coming faster than people think.
Imagine a near future where the local protocol isn't a static document, but a real-time, patient-specific AI guidance system.
The AI is directly reading the live telemetry, the EKG, the arterial blood pressure, the pulse oximetry.
It has already scraped the patient's entire electronic medical record, identifying their exact renal clearance rates, their pharmacogenomic profile, and their home medications.
So when the end tidal CO2 spikes and the heart rate jumps, the clinician doesn't have to reach for the MH manual.
The AI recognizes the pattern instantly, projects the highly specific, customized algorithmic steps onto a heads-up display, and automatically cues the pharmacy system to dispatch the correct, weight-based dose of the reversal agent.
See, it is scientifically viable and currently in the experimental phases. It promises to virtually eliminate the cognitive bottleneck of human working memory.
However, it introduces an entirely new, potentially terrifying dilemma regarding reliability.
The black box problem.
Precisely. If a machine learning algorithm is dynamically generating clinical instructions based on neural networks and vast data sets, how does the clinician verify the methodology?
You can't just read the methodology section like you can with a grade guideline.
Right. If the AI suggests an intervention that contradicts the clinician's gestalt, how do they know if the AI is identifying a subtle, brilliant correlation in the data? Or if it is hallucinating based on a corrupted data set or a poorly weighted variable.
If the clinician overrides the AI and the patient dies, they are legally liable.
But if they blindly follow the AI and the patient dies, who is liable?
We spent this entire deep dive discussing how professionals evaluate transparency, evidence grading, and the rigorous vetting of human task forces.
But if the algorithm itself becomes an opaque black box, how will the clinicians of tomorrow evaluate the reliability of the very intelligence guiding their hands?
That transition from evaluating the static methodologies of the past to trusting the dynamic, algorithmic intelligence of the future will be the most profound tightrope walk the medical profession has ever attempted.
It is going to fundamentally redefine what it means to be a clinical expert. Thank you for joining us on this exhaustive deep dive into the information architecture of the perioperative world.
It's been a fascinating rabbit hole to go down.
We really hope this exploration changes the way you look at the resources you utilize in your own high-stakes environments, whether you are managing critical infrastructure, aviation, or enterprise systems.
The principles of reliability apply everywhere.
The next time you think about the concept of anesthesia, you'll understand that keeping a patient alive on that physiological tightrope is not just about the drugs in the syringe. It is about the invisible, deeply complex layers of data keeping those hands steady. Keep questioning the consensus, always look for the methodology behind the mandate, and we will see you on the next deep dive.